if you look at the trends on the data, it's pretty stable. Hospitalizations are pretty stable. Looks like we're hopefully at the top of a very flat curve.
Social distancing works. Once you lift up social distancing, what happens right now is kind of anybody's guess.
There's a lot of talk about when and not enough about how. And that's the how part that's really important.
Hey everybody, welcome back to the Vitalyst Spark podcast. I'm your host, John Ford. All of us who are part of this show's development, writing, editing, and production are deeply grateful to you for your feedback on what we're doing with this podcast. As we've stepped things up to get more information to you during COVID-19, you've really ramped up your listenership, your social media shares, and your comments and compliments, which is why we're back today with our latest twice-monthly COVID-19 roundtable discussion. This time around, we are sadly one member short of our usual crew, and yet we still found plenty to discuss. Health policy, infection testing, contact tracing, antibody testing, reopening, health policy, economics and the social determinants of health, psychology, public health, and the list goes on, including one or two bad jokes. The good news? You don't have to rethink your personal stance on physical distancing practices in order to get these updates from our roundtable guests. All you need to do is listen and take a moment or two to reflect as you do. The pace of COVID-related change may be starting to shift. If that's true, we all need to take advantage of the opportunity to process where we've been and smartly plan where we want to go together. So let's get to it. It's time to talk about how we move forward, centering health and equity in the context of COVID-19. Today, our COVID roundtable returns, -1, unfortunately. Marcus Johnson unable to join us today, but we still have Mr. Will Humble. Will, how are you?
Good. Thanks for the introduction and opportunity.
Thank you for being here. And Nick Vasquez, how are you doing today?
I'm doing well, thank you.
Great to have you guys back. Let's get into the discussion. Let's do it like we have every other time. It's been 2 weeks since the last episode. What's changed in the world? How is our worldview supposed to look in terms of COVID-19? What about elective surgeries returning? What's going on?
So when you look at the data trends today, where we are right now compared to 2 weeks ago, we've been doing this for about a month and a half. The thing that strikes me this time is how little has changed in 2 weeks. Because remember, earlier, tons of stuff had been changing in 2 week period. It seemed like 2 years. Now, if you look at the trends on the data, it's pretty stable. Hospitalizations are pretty stable. Looks like we're hopefully at the top of a very flat curve on hospitalizations. Same thing on number of new cases. Same thing with the percentage of ICU beds that are being taken up by COVID-19 patients. So in the last 2 weeks, I think things have been really actually stable, which is what's different looking back at the last 6 weeks.
Other than a run on Lysol products, everything's pretty much the same.
Oh, that stuff.
Nick, what about in your world? What's going on in the world of frontline healthcare workers and the world of hospitals? Similar?
Well, I think the world of hospitals is very focused on getting elective surgeries reopened again. Basically, everybody's budget gets set by their operating room. Whatever procedures you get and then whatever income you get, a hospital runs and survives on its operating room. As long as that's been closed down, these hospitals are hurting a lot for money. But in the ERs that I've seen, aside from Flagstaff, there's really not a lot of overcrowding. In fact, we're down 40-50% still. We are worried that people are staying away and suffering strokes or heart attacks or all sorts of stuff at home for fear of coming to the emergency department. I've tried to start to tell people it's okay to come to the ER. We found ways to keep you safe called masks.
Yeah, people have been asking me that. I've been doing some media interviews and stuff, and a lot of them will ask, how can they meet the needs of patients? I kept saying, hospitals have been in the infection control business for the last 150 years, and they get better at it every year. This isn't anything that's new for a hospital. Hospitals are really good at infection control. And so, yes, this is a new virus. And yes, it poses particular challenges. And yeah, the supply chain of PPE has been an impediment, but they're good at infection control. People shouldn't worry about that.
Yeah, the PPE thing is still a problem nationwide. And this is where I speak big picture. We still have the same problem. So if we're at this point now where we know infections are going down, where we know hospitalization rates, which is really the one that I like to follow, it doesn't depend upon testing. It doesn't really depend upon whether or not folks are doing active management. Your sickest of patients are going to come in and get hospitalized. And so it just gives you a sense of which direction you're heading. I wouldn't put too much faith in numbers. I've seen a lot of people point to numbers and say, see, look, there's only X many cases. And just understand we're missing a ton of them because we're not really testing or they're not sick enough. So just take it with a grain of salt. But if you can watch the curve, you can see the trend of things. Because of that, we're very certain that social distancing works. There's been a number of studies I've seen thrown out there, from studies of social distancing in China or social distancing in UK. And then we have our own data here in Maricopa County. Social distancing works. Once you lift up social distancing, what happens right now is kind of anybody's guess. We know the infections will go back up, but how fast, at what rate, kind of all depends upon whether or not people continue with social distancing, use masks, wash hands, and how much of the economy we reopen.
And how those businesses that do reopen behave in terms of mitigation. And so one of the things that I've noticed in the community in the last month really is those businesses that have been called essential services or essential activities by the governor have been open. So places like AutoZone and Home Depot. And I've had to go out and do things over the last month. I can look back at Ace Hardware, for example, in the last month, where they were 3.5 weeks ago compared to where they are today on mitigation. And they've come a long, long way, and a lot of businesses have. And so I think there's a lot of talk about when and not enough about how. And that's the how part that's really important, is the businesses that then start operating, whether that's a restaurant at a lower capacity with mitigation things in place, or whether it's manufacturing to come up with ways of protecting the workers, finding creative ways to limit exposures between customers and staff and among staff. The how part of it is under talked about compared to the when.
Well, isn't this sort of the thing? I mean, we just said the one indisputable fact is that social distancing works. And yet it's still the only qualified tool we have to control the spread of this virus at this point. Because we don't have contact tracing. We're not doing enough testing. We're going to try to do those things, but we're not there yet. So right now we have one tool. And so that one tool is working. And so it would only make sense that the next key thing to work on, given that that's our only tool, is adaptation.
Right.
Okay, so that gets back into the great reopening debate. This great reopening debate has a lot of mimic for the climate debate. Some people want to deny the science and say it's not that bad, it's not that deadly, we should just reopen and we should just let people take their chance. You know, it's all about the economy, and you got other people on the other side saying you don't know that. My worry is this: as you said, just one tool called social distancing. There are, at least in the United States, 350 million potential infectious cases. Everybody could get it. The mitigation that we have to do will make a lot of these business models not work. If you're a restaurant, you make most of your money off of the bar and off of alcohol. And if you have 60% of your business and a lot of people maybe aren't staying in and aren't ordering alcohol, does it still work? If you're an airline and you can't use your middle seat because you have to separate people, does the business model still work? These are my questions right now. Regardless of what debate we're having, business models either work at a certain level or they don't. And I think a lot of these businesses aren't going to work once we reopen unless it's ollie ollie oxen free and everybody goes out and does exactly what they want to do, which is the way we guarantee the most infections.
So then we can go two ways with this conversation. We can talk about there need to be more tools developed, like testing and contact tracing, or we can say, like you said, ollie ollie oxen free.
So here's the way I look at it: is this social distancing and the shutdown order, it's a pretty crude tool. If you look at the side effects that it has, the real life consequences with working families and really everybody, it's a pretty primitive tool, to be honest. But it's working, and it has flattened the curve. It has achieved so far the objective, which was at the beginning to flatten the curve so that we don't exceed our hospital capacity and ICU bed capacity. That was the justification for the interventions. And so now we're to the point that it is working given the capacity that we have. So the question becomes, how long will it take so that we get down to a manageable number of cases and at the same time ramp up contact tracing capacity at the counties, which they're beginning to hire now, or at least working with their personnel departments on hiring some folks. If you bring up your capacity on the contact tracing at the same time that this crude tool of social distancing is continuing to work, if you come to a good landing spot, then perhaps we can start relying on this more sophisticated tool of testing and contact tracing as opposed to the crude tool of shutting down businesses, having all these side effect consequences that affect the social determinants of health.
Push back on the side effect stuff. Just one thing. And let me ask you just this question. We reopen the economy. It's everybody choose your own risk. Let's just let you decide for you. Scale of 1 to 10, how likely are you to go out to a restaurant? And if you're out at that restaurant, scale of 1 to 10, how likely are you to stay if someone starts coughing? I'm not saying 10, I'm going to go out to a restaurant, absolutely, and 10, I'm definitely going to stay despite someone coughing. That means that consumer behavior will change regardless of what we do.
I agree.
If people perceive a risk, business models will be at threat anyway.
Right. So that's documented. There was a survey that was done maybe a week and a half ago now, 3,500 people nationwide, and 70% said, knowing what they know now about COVID-19, they wouldn't go anywhere. And another 10% said they would have to think very carefully before they went anywhere. You were absolutely right about that. But I also want to go back to this notion of a side effect. It's not even a side effect, right? When you shut down this much of the economy, we see a lot of broken pieces on the ground. We see places that were already living on the edge that have completely fallen off the edge. And that's not a side effect. That is a systemic effect, and it's a big one.
That was the entire point of the London study back in the beginning of March. The Imperial College of London put out a study about these difficult choices that with asymptomatic spread and without effective testing and contact tracing, you were really left with non-pharmacologic interventions like shutdowns. And that the shutdowns were so economically damaging that it was a real difficult choice. Their conclusions, and you can argue with their numbers, but their conclusions were we were facing either 2 to 4 million deaths in the U.S. by the end of the year, or we shut down the economy and people go into recession/depression. And I'm sure we're going to try and find a middle way with partial reopenings and supportive laws and bills being passed by Congress. But imagine if we did nothing. Then imagine if we did something like Sweden. And then imagine if we did something like we've done. Each one of those is different scenarios with different outcomes. I read this great article about Sweden, which has basically kept their schools open but tried to protect the weakest among us, or the sick and the most vulnerable. They said they could do it, and I'm going to quote, because people trust the authorities and the authorities trust the people. And I would argue that there is a lack of trust in the United States for us to pull this stuff off.
And which would probably bring us to the Capitol protest, but I'm not going to go there quite yet because I want to make sure that we are crystal clear that when we talk abstractly about shutting down the economy, it almost sounds like a logical decision. But what we're really talking about is the destruction of people's capacity to survive, let alone thrive. Like Will said, that is a blunt tool, and it has very considerable effects to the point of literally an entire town or city in rural Arizona calling and saying, we don't have any food, let alone emergency food. Like the shelves are also empty on the grocery store. These things have never happened before. And what are we going to do about it?
We have this strange relationship with government in the United States. Once government power gets involved, the debate shifts to government power. I want to sound like a broken record, where let us not forget this is a pandemic first. The whole government shutdown isn't enforced by cops. There's no one who's been arrested in Arizona for having a restaurant. They've been asked to shut down. There have been authorities who have been involved. But honestly, there's not an enforcement arm. And as we go forward, I doubt there's going to be an enforcement arm. I doubt there's going to be anybody who's put in jail. It's difficult because it's this pandemic first. Most of our economy is built upon services here in Arizona, and services require people to be willing to spend money. Those services require people to be willing to be physically present. And those things are kind of impacted first by the pandemic. So whatever policy we have to resolve this pandemic because people's behavior will change because they perceive threat. Mm-hmm. How much threat? I don't know. But let us not forget, as we focus on this government action and its attendant consequences, that even without government action, there would be attendant consequences like whole parts of the economy would shut down. Complete sectors of the economy are under threat. If you go back to the beginning of a pandemic and you kind of take this wide scope and realize that this changes everything we assume, that you have to stop assuming that what was normal before will continue on.
It sounds so obvious, but I hadn't actually thought about that. We talk about this as this was a top-down decision from governors to decide to issue these executive orders that shut down preemptively pieces of the economy for social distancing purposes. And so my frame of reference has really been from that executive branch sort of top-down mentality. But you're absolutely right. And I hadn't thought about it until you just said it, which is, let's say you didn't do that. The effect is still the same because people's psychology would keep them home, which shuts down the economy from the bottom up.
Yeah.
And you get the same negative results in terms of the social determinants of people able to make a living. But instead of top down, it was bottom up. And so I'm glad we talked about that.
I think everybody's always thought about it as the government forced us to do this. There's no question about that. And I think that what we see when we look at the protests that just happened last week at the Capitol, where people wanted their state reopened, they were railing against government. So I do think many people have that point of view. I think there are 2 points of view that need to come more firmly to the forefront. One is this is not going to be different anytime soon. And the second is no matter how we got here, the impact is such that we've got to figure out how to repair broken systems that are right now not keeping people safe. And when I say safe, I don't mean safe from the virus. I mean able to survive and thrive.
Yeah, I'm more on the able to survive. The thrive part is nice, but that's different part of Maslow's hierarchy of need. That's dare I say it, that's a rich person word. How do I thrive? How do I succeed? In all of this social determinant stuff that we've done, you and I have done presentations together, and you just can't understand how different people's lives are if they do or don't have the ability to read by age 8, or did not have a loving household when they were young. Those have lifelong impacts, and their ability to respond to crises is dependent upon their ability to work a job, which is dependent upon their ability to graduate high school, which is dependent upon their ability to read, which is dependent upon whether or not someone actually read to them when they were kids, right? It's this cycle that kind of begets the cycle. And now that we get into the social determinants, what we reveal isn't that the virus is specifically picking out certain groups. Those groups were always more vulnerable. Those groups always lived with a higher level of disease. Those groups always had less money to respond or less access to health care. And this pandemic has just revealed what was sort of hidden by our daily lives, is that some people have advantages called, I had a loving environment from 0 to 5, and I knew how to read by age 8. And some people don't. And those people that don't have that advantage are really struggling right now, both economically and health-wise. I live at 30,000 feet. I forget where the heck I'm going when I go to the grocery store. But being an ER physician, I had to see all of society's problems in patient form. Every ER I've ever worked at, every patient that shows up is somebody who ostensibly could have either been taken care of elsewhere or maybe should have been addressed earlier in the chain of disease. Some things you just can't fix, right? You can't stop strokes, you can't stop MI. But as we have divested in public health, I see more consequences for those policy decisions. I always like to say that ERs have a business for 5 bad reasons: bad choices, bad habits, bad luck, bad genes, and bad policy. And over the last 20 years or so that I've been involved in ER, there has been a broad retreat from the idea that public health is our business. It's almost like an afterthought. We've decreased in preparedness. We've decreased in public health investment. And that kind of is a bitter pill for me right now, given the fact that we don't have the staff to do contact tracing. We have antiquated systems to track patients. We just don't have the tools of modern economy to help our modern economy with this public health problem.
Let's shift to that. What does it really take from a public health perspective, and quite frankly, from a public trust perspective, like we just talked about, to eliminate fear and yet still manage a virus that we do not have a vaccine for?
I think we're at the top of the curve now, a flat curve. If we can get the cases to come down to a manageable level, that's a steady decline. Same thing in terms of hospitalizations. And then if the popular media follows that trail and continues to report what's actually happening without being sensational, then I think people can start to get more comfortable. Then you got to have a ramp up in testing and contact tracing so that you can keep everything to a low boil and hopefully stay for a few months at a flat level. And then I think many people will begin to return to consumer spending activities. Not everyone will. Like you said, some business models with a margin that won't accommodate that will end up going upside down, but many will be able to keep the wheels on. Part of this whole thing is really human psychology. How do we get people to feel comfortable again? That we need lower hospitalization numbers. We need easy access to testing, some confidence that people are being followed up on so that mystery is removed about who's been in contact with somebody or not. Because if you've got a public health system that can identify people quickly with testing, and then someone from a county health department gets that person, ensures that they go into isolation, and then talks to each of their contacts, then people can feel more comfortable that, hey, the number of cases are down. I feel less at risk because of that. And if I had been exposed to somebody, that someone from the health department would actually come and talk to me about it, and I would know. But we have to get to the place where there's fewer cases in the community, and people come in all different mindsets. And there's going to be people out there that as soon as the restrictions are lifted or they have money, they'll go out and spend it on things. And there's other people at the other end of the spectrum that will never come out of the house for another year, even until there's a vaccine. And there's people in between. That's what I think is we got to get to a place where people are comfortable getting out and spending and they don't feel at risk.
So there's this old phrase that goes, in the absence of a story, people will make one up. Equally applies here. In the absence of data, people make data up. How many times have you heard in the last 3-4 weeks, you know what, I think I may have already had it?
A lot, especially in my group. Some people actually probably did, now that I think about it. We've had a couple of providers actually get it, despite relatively low numbers compared to, say, Flagstaff or New York. We had a couple of providers come down with fever and cough, and we assume that they had it. You know, the testing's been such a debacle, and it continues to be a debacle. I heard over the weekend, Dr. Fauci mention a number that we can do 1 to 2 million tests a week. For us to really open up, there's one plan by an economist named Romer, where everybody in the country get tested every 2 weeks. And that requires the ability to do 22 million tests a day.
At a 70% accuracy rate, I believe.
Right. And you follow the hospitalization curve anyway, and you're kind of always watching. But who's watching? That's my question. Because if we're doing contact tracing and testing and we're trying to let everybody know, what group does that? Is it the county? Is it the state? Is it the healthcare system? Is it the city? How do we track this stuff down? Because the how really matters. As you mentioned before, not just opening up the economy again, but how do we reopen it? How do we take care of people? The essential workers so far have been largely people who work for the lowest of wages. They have to be physically present to do their job. Everybody else who's been stuck at home with their kids has white-collar jobs or jobs that you can do online. I know the future like you do, but there's a couple of trends that I think are going to continue. People who can work at home might continue to do that. The telehealth is, I don't think, going to go away. But any job that requires both the physical presence of the worker and also physical presence of a consumer is going to be impacted by people's perception of safety. So unless you've got a mechanism where which we can test the public reliably and you can then report actual data to a polarized media world and then have people actually trust it, then you can kind of get things to resume. But I've seen elderly people stay home having a stroke because they were too afraid to come to the ER.
There's sort of a real-time negotiating going on of new civic norms and behaviors, right? If any of us have been at the grocery store and felt one person staring you down versus the other, like, who's going to go for the milk first? How do I keep 6 feet away from you? How come you're not wearing a mask and I am? All that kind of stuff is going on right now. From a public health standpoint, how could there be more leadership to help bring some transparency, some level of understanding of what the virus really is and does, and how we should be behaving with each other respectfully?
That's a big question. You know, I don't know how to answer that.
Going back to COVID, I'm going to stick to where my expertise is at. So I've been neck deep in trying to learn about COVID as much as I can. So there's two things to share. One is that a Chinese team of researchers did isolate neutralizing antibodies from survivors and made monoclonal neutralizing antibodies, and that would be a real game changer for me. But the numbers were interesting. They did it by taking 26 people who survived the disease, and they tried to look for the antibodies, and they found that essentially 3 people made what was very likely neutralizing antibodies, 3 out of 26. And then when they went to test specifically in vitro, they found it was 2. So in this one little series, 2 out of 26 people made actual neutralizing antibodies. I don't know if you can take anything from that other than the fact that we have a monoclonal antibody that seems to neutralize COVID, which can be used as a treatment, and I'm hopeful for that. The other thing is there's been a change in thinking. The thinking around coronavirus has been all over the place. And we're all learning over these last 6 months. What is it? What isn't it? What does it do? What does it not do? So it may change again. But the thinking right now is that it most resembles a rare chronic disease called HLH. And I'm going to absolutely butcher the way it's spelled and the way it sounds, but it's hemophagocytic lymphohistiocytosis. Please don't make me say that again. It's a rare disease where people's immune system goes haywire. And basically, after an infection or cancer, the lymphocytes and the histiocytes kind of start attacking the body. And there is a lot of overlap between the COVID-19 disease and HLH. The overlap is that we think right now that SARS-CoV-2 infection creates a crazy immune system, which then goes into overdrive and starts attacking the human body. You'll get neurologic symptoms, you'll get skin symptoms, you'll get GI symptoms, you'll get pulmonary symptoms. People can progress, if untreated or really bad, into a cytokine storm, which then leads to organ failure and death. But this is the closest mimic I've seen so far to explain all the really weird symptoms that the sickest people have. This would mean you'd probably see a genetic variant that make people more or less susceptible to it. And then you would also see environmental barriers. Those environmental barriers would be older age, inflammatory state already, just the propensity of living with illness like hypertension, heart disease, diabetes, which brings us back to the social stuff. Since hypertension, diabetes, and obesity is associated with poverty, because poverty means you can't afford good food, which means you can afford processed food, which means you're more likely to be obese and diabetic. There is an equity part to this conversation about reopening that we haven't had. Is it fair to have a reopening of the economy and then to tell some people, sorry, you're held out? Is it not fair? Is it fair to reopen the economy when most of the essential folks have already been at risk and those folks were the ones who were the poorest already? I don't have the answers. I'm just saying this is part of the debate. I know we can't stay closed forever. I know we can't protect everyone. But there's this equity part to it that we kind of haven't dealt with that I'm really worried about.
Right. Well, our capacity to deal with inequity has been pretty low for a very, very long time. By the way, I believe the correct pronunciation of HLH is supercalifragilisticexpialidocious. I'm pretty sure.
We haven't talked about antibody testing yet. I've heard there's a big announcement. U of A is going to partner with money from the state health department to test healthcare workers and first responders and look for IgG and IgM antibodies. Here's the thing. One of the ways to change human psychology around how they respond has to do with have they had it or haven't they had it. And so I think there's some decent evidence. The Santa Clara study suggests that there's far more people out there that have had this illness and recovered than we realized, as many as 50 times more people than the number of reported cases. Still a low percentage of the population, we think. But if we've got a reliable antibody test that somewhat works, it can give some people confidence that they can get back to their lives because at least they're not at risk themselves and probably not at risk of spreading it to others. And one of the reasons I wanted to bring this up, some scientists at WHO over the weekend, and sometimes I think they release stuff on weekends because they know they can get a lot of traction. And so I don't think the WHO did themselves any favors by at some conference suggesting that if you get this illness and recover, that you're not going to get it again and again. And I know we don't know, but what's the purpose in an environment like this when everyone is so scared to just throw that out again and say, oh, and by the way, if you got it, doesn't matter, you probably are going to get it again. That's the message they were sending, and it just kind of ticked me off because this is stressful enough for everybody. And then to do a gloom and doom report, it just kind of irritated me.
But that's exactly what I was asking you earlier, is how does public health take a leadership role in restoring people's confidence?
There's a really, really good way to do that. And I think we've missed this opportunity, but to communicate to people in grades of how certain we are. So that rather than kind of say a report is a report is a report and take it all for news, but to acknowledge that there's some things that we think, some things that we know, and some things that we can prove. I borrow that from the movie And the Band Played On. I think it's really an effective way to help people understand I've got theories, but just because I'm an expert doesn't mean I'm right. It just means I got theories. So here's this little study that we did, convenience study. We signed people up through Facebook, and we gave them a little test to see whether they had antibodies or not. What I haven't seen from that Santa Clara study, which is exactly how they did it, was whether or not they had high levels of specificity. That test has to have a really good negative predictive value, because if not, then you're going to get a lot more people who have false positives than true positives, and then you've got a dangerous test. Because people go out thinking they got antibodies when they don't. I think from the WHO's point of view, I didn't agree with that crisis communication. I think you need to think about the words that you're going to use and then impacts the audience. But I think from their point of view, they're trying to say, what can we prove? Well, we can't prove much. Right now with this virus, we can't prove much. We think you get antibodies. We know most people have when we're looking for it, but we don't have a good enough data yet to prove it. Okay. If you can communicate in gradations of certainty and acknowledge that I'm uncertain, then you save yourself from the other part that happens in a pandemic. Because the other part that happens in a pandemic is only the most certain voices get promoted. I don't know why. People hate uncertainty. But the people who feel the most certain and the ones who make the most demonstrative claims somehow are the ones that are trumpeted. No one is an expert in COVID right now. We have 6 months of world experience. No one is an expert.
You're totally right about that. The people who sound the most determined that they're right and don't show uncertainty are the ones that get on the television and then get on the radio and get quoted in print over the nuanced type of folks. You know who's been doing a good job? Tom Frieden, who's the director of CDC under the Obama administration. He's been doing, I think, a really good objective job at calling it like it is. But because it's more nuanced the way he talks, he's not the person who gets the top billing like what happened over the weekend with WHO thing. You're right about that. But going back to the question you asked me about communication, I think the bottom line is to just level with people and just be honest. Some of the things I've seen, heard, et cetera, tends to make the administration look good or add spin to things, and just level with people, you know? And if you don't know, it's okay to say you don't know. People are people. That's how they live. They're not certain about everything. But I think if you're straight up with people, you'll get respect. That's the best policy. I'll give you an example from over the weekend. Last Friday, I think the state health department says we're changing our guidelines on diagnostic testing, and anybody that wants a test can get a test. That was the messaging. And I remember thinking, as second I heard it, I'm like, it should have been anybody who thinks they've been exposed now qualifies to be able to get a test. But that's different from saying you can get a test, because the transport media and the swabs aren't there, then you can't get the test. And so we know that there's a short supply of these things. And to say anyone can get tested, you're setting yourself up for failure, because you've set an expectation in the community now that anyone can get a test when that's not true. You opened up the criteria so anybody who's been exposed qualifies if they can find one. Mm-hmm. It's a different thing.
The governor's stay-at-home order expires 3 days from this recording. If you were governor, what would you do?
I'd leave it on for at least another 2 weeks, even though it pains me to say that, because I'm as impatient as a public health person as I think you'll find on these things. It's because I think we need to get down to a threshold where the county health departments have the ability to do contact tracing. We need to get down to a level, we're at 250 cases a day, something like that. Let's say we can get down to 50 cases a day or 75. If the county health departments have staffed up to the point where they could do contact tracing at that level, then I think you can ease up on the restrictions and be comfortable that you've got some tools in place other than just the stay-at-home order, which would be the contact tracing, et cetera. I just would hate to loosen things up right now in 3 days and have this top-down economic damage be for nothing. So I think I'd do a couple weeks. And the other thing I would do is, in the meantime, use those 2 weeks to do all hands on deck information out to the businesses on the practical things they can do for mitigation to prepare for mid-May when some of the restrictions could get lifted.
Nick, same question to you. It's 3 days from the expiration of the stay-at-home order. You're the governor of Arizona. What do you do? And oh, by the way, you had to drive to work a couple of days ago facing a whole bunch of protesters.
I think you stay the course, and I think it's because once you lift it up, it'll be very hard to put back. I would give it a little more time to get the hospitalizations down and then to get the contact tracing and testing in place. Even though the state has already said, well, a lot of people can get testing, the hospital systems push back and go, actually, no, we can't. We don't have the tests to do that. So the stuff he's done is some good work. I think we're getting closer. But you need some more time to sort of prepare the systems that we're all going to count on to keep us abreast of what the infection is doing. So I would extend it for a little bit longer, and I'd allow the hospitals to reopen the elective cases.
Yeah, and get contact tracing up and going. That has to happen in the next 2 weeks. I'd do an executive order suspending some of the personnel regulations and things like that so that they can get some of the new graduates from the MPH programs and stuff a job doing contact tracing and guarantee them for the next year. And by the way, do loan forgiveness or something like that to keep them in place, because you're going to need this group of people to have assurance this is a real job.
There is one hospital system in crisis, close to overwhelm, or if not at overwhelm. And if it were in Phoenix, we'd be talking about it, but it's not. It's in Flagstaff.
You're right.
How should the state, how should philanthropy, how should public health be responding in a way that brings some relief to northern Arizona and particularly to the Navajo Nation?
You know, it's really hard to say. You have to, we talked about it last time about that sense of trust. You've got to get resources, you've got to get information, and you've got to get staff. Just this morning, and it's on New York Times, for example, in New York, an ER doc committed suicide after 2 months of dealing with coronavirus. Apparently she couldn't take it anymore. The staff that's up at Flagstaff needs help, needs a break, needs time off. Most simply, that's what I'd think of. I think of the humans who are going to work every day and whether or not they need a time or break, or what kind of support do they need, how much PPE do they have. And then beyond that, the devastation within the Navajo and Apache counties. You know, what do they need? There's no short-term answer. You keep that big, broad hammer of stay-at-home order out there until the infection rate and the hospitalizations go down. It takes 2 weeks for a change in the infection rate and 2 weeks after that for a change in the deaths. It just takes time.
Will, your thoughts about Flagstaff and Navajo Nation?
I think that is your critical point right now in the system. And so there's got to be some tools at hand. It's $100 million the legislature gave the executive branch. There's got to be ways to use those resources to get some emergency relief up there for those clinicians and some additional resources. So I think that needs to be a priority. And other than that, I think you just stay the course for another couple weeks and get mitigation plans in place for the businesses to prepare for the middle of May. And then make sure you do the hiring and the contact tracing in the next 2 weeks so that you've got people to be able to that can actually follow up on new cases and start doing that contact tracing in the middle of the month. And cross our fingers that the heat does something to this virus too. I think in 2 weeks, it'll be really interesting to see, does the hospitalization trend look good? How successful have we been in increasing the number of tests? What does the initial information from the antibody test look like? The governor extends the order for another 2 weeks. It will only be a few days before that will come up again. 2 weeks is, I think, will be an interesting one.
Can I put it succinctly and say that your magic wand would be staff up for public health and testing and tracing?
Yeah, that has to be the number one priority, is contact tracing, so that you can substitute a more refined intervention like that for what we have with this big, broad stay-at-home order, which is a blunt instrument, and hope it works.
And Nick, your magic wand for the next 2 weeks?
Honestly, if we don't have the ability to afford contact tracing like actual people and staff, then the other option is to permit our phones to spy on us. I think I'm more comfortable with actual contact tracers and empowering the government to keep track of us rather than having my phone and Facebook keep track of me.
I think people will feel more comfortable that if I've been in contact with somebody who's positive, that someone's gonna find me. instead of me relying on some electronic instrument to do that. To build the comfort that's needed for people to start spending again, they're going to need the comfort that there's an effective contact tracing so that someone's going to find them to tell them that they've been in contact with somebody. And so that system has to be present. And with community spread, you can't do it. There's too many cases at 250 a day.
Yeah.
And they need to get staffed up. But that CARES Act is giving county health departments more money than they can possibly spend. And maybe that's something we could do at the end of this thing about how during H1N1 and the Ebola thing, even to some extent years ago at West Nile, there's this underfunding of public health systems year after year after year. And then something comes up like H1N1, like Ebola did, like this is, then you open up all the spigots and health departments can't spend the money.
Yeah.
And it's not effective use of money because what you really needed was to spread that money out, this CARES Act money, to the public health system over the last 6 years so that you could have a career pathway and create the talent that you need for the times that we're in. But now there's just more money they could possibly spend. But I think there's new graduates coming out of college that could be really useful as contact tracers. And I was talking to Maricopa County about that as a possibility. And they're already looking into that, new graduates coming out with a guaranteed job of being able to do that kind of contact tracing and get their foot in the door. This would be a terrible time to graduate any trade at all. This would give a career opportunity for somebody in an area that's really needed badly.
Thank you, Nick. Thank you, Will. And Marcus, we'll see you at the next roundtable in a couple of weeks. With data, research, and public health experiences growing, there's no question there'll be more to chew on then. For those of you who haven't heard all of our COVID roundtable discussions, it can be pretty interesting to see how the conversation has grown and evolved. Part of our mission with the twice-a-month roundtable is to create a sort of time-stamped audio diary. We can check in on what our past selves thought 2 weeks ago, 4 weeks ago, and so on. Of course, you'll get a fuller picture of what's happening in Arizona right now when you listen to all of our episodes. That's why we're keeping you in touch with other aspects of what's going on in between roundtables. For example, we released our 2020 census episode a few weeks ago and just released our discussion with the Maricopa County Food System Coalition last week. If you missed any of this stuff, no problem. You can visit us on the web at vitalysthealth.org/podcast. Check out all of our current and past episodes on Spotify, or simply reach into that podcast app you're using right now and select another show to find out what's going on related to health and well-being in Arizona. That's it for this episode. The takeaways from this dialogue belong at the family dinner table as much as they do in your place of business, in city and town halls, and in the domains of healthcare and public health. So please, share this independent episode far and wide. Subscribe to the Vitalyst Spark podcast to get notified as soon as new episodes are released. And like we mentioned above, we've got great news on that front. The Vitalyst Spark is now available on Spotify, and you can subscribe to be notified of new episodes there too. In the world of podcasts, you can give us your feedback on Apple Podcasts, Google Podcasts, Stitcher, Overdrive, or wherever you get your podcasts. You can also give us your input the old-fashioned way. Your corrections, complaints, and compliments are all welcomed by emailing us at feedback@vitalysthealth.org. Finally, remember this. With great responsibility comes great power. We'll see you back on the road to well-being soon.